Today our teaching is about dementia. The objectives of this teaching are to differentiate normal memory loss from dementia and other conditions that can masquerade as dementia. It's also important to understand how the different types of dementia affect the brain and to discuss symptoms, diagnosis, and treatment. What a lot of people don't understand is that dementia is simply an umbrella term, and this term is used to describe a range of conditions which cause changes and damage to the brain. Now, this damage results in a decline of the patient's cognitive abilities. So this means the capacity to understand concepts, to process information, to sustain concentration on a task or even a conversation, or the ability to remember details and people, the ability to speak and reason, and to utilize motor skills. I work with the elderly, and many are worried about the possibility of dementia. They say to me, I walk into a room and I forget why I walked in there. And I say, well, I've been doing that since I was a little girl, so you don't have anything to worry about. But they don't understand that there's a huge difference between age-related memory loss and dementia. So let's look at this for a moment. So if we look at normal aging, that's simply not being able to remember details of a conversation or an event that took place a year ago. But dementia is not being able to recall details of recent events or even conversations. In normal aging, it might be not being able to remember the name of an acquaintance. In dementia, this would be not recognizing or knowing the names of family members. Normal aging would be forgetting things and events occasionally. Dementia would be forgetting things or events more frequently. In normal aging, maybe somebody occasionally has difficulty finding words. With dementia, there is frequent pauses and substitutions when finding words. Now, this next one I would say would be the most important defining factor. In normal aging, you are worried about your memory, but your relatives are not. In dementia, your relatives are worried about your memory, but you are not aware of any potential problems. There's another issue too, and that is medications. There's a list that was created called the Beers list. And of course, the person that created this is called Dr. Beers. Now, this list is an effort to curb inappropriate prescribing of medications for the elderly. And this is actually another subject, but on that list are medications that can masquerade as dementia. So one needs to make sure that someone that is experiencing memory problems is not taking these medications. And these are just some of the more common ones, but a huge offender is common anticholinergic medications. Now, the most common anticholic medications in studies that have been shown to masquerade as dementia. So I will just rattle off the most commonly used ones. Amitriptyline is commonly used for sleep. The paroxetine is commonly used for depression and anxiety. The other ones I don't see used so often, but it would be good to check for those. A huge one that is used as an antihistamine for allergic reactions is Benadryl diphenhydramine. This is also in your sleep medications. So anybody that takes Tylenol PM or Advil PM has diphenhydramine in it. Hydroxyzine is also utilized a lot for itching. Hydroxyzine is also used as an anti-anxiety medication. So that needs to be checked. Another huge offender that I see a lot is oxybutynin. This is used for urinary incontinence, especially in women. The other one is the Detrol or the tolterodine. Vascular, I don't see that a whole lot. The antipsychotics are a bit tricky. So your Zyprexa, the olanzapine, your Seroquel, which is your quetiapine. because those are used for a lot of the mental health patients. So your bipolar disorders and other mental health disorders. So for many years, maybe people have been on these medications to stabilize their mental health disorders. So this is where you would probably need a geriatric psychiatrist to come in and advise on these medications. So anyways, though all of those are common medications that can masquerade as dementia. Now, there are also medical conditions that can masquerade as dementia. So a few of them that can mimic dementia and should be ruled out are the following: mental health disorders, infections, even thyroid disease. People can also have vitamin deficiencies, especially vitamin B12 deficiencies, Lyme disease, people with vestibular disorders. People who also have migraine disease can have a lot of cognitive dysfunction. So there are many different types of dementia, and all of us have heard of Alzheimer's disease. And of course, this is the most common type of dementia, making up about 62% of dementia. And of course, you'll hear different percentages on all of these, but this is a basic ballpark percentage. The second most common type of dementia is vascular dementia, and we'll discuss all of these in order. The third listed is mixed dementia, but that is actually just several types of dementia going on at the same time. The fourth listed is Lewy body dementia. Tied for fifth is Parkinson's dementia, which is closely related to Lewy body dementia, and frontotemporal dementia. And then there's several types of rarer hereditary types of dementias, which we are not going to talk about today. So of course, we're going to start out with Alzheimer's disease. So Alzheimer's disease, of course, is named after Dr. Alzheimer. In 1906, he noticed changes in the brain tissue of a woman who had died of an unusual mental illness. Now, her symptoms included memory loss, language problems, and unpredictable behavior. After she died, he examined her brain and he found many abnormal clumps. Now we call those clumps amyloid plaques, and he also found tangled bundles of fiber. And now we call those tau tangles. So these plaques and these tangles in the brain are still considered some of the main features of the disease. Now, another feature is the loss of connections between the nerve cells or the neurons of the brain. Unfortunately, Alzheimer's disease is an irreversible, progressive brain disorder that slowly destroys memory and thinking skills, and eventually the ability to carry out the simplest task. In most people with Alzheimer's, symptoms first appear in their mid-60s. Now, experts suggest that more than 5.8 million Americans, most of them 65 or older, may have dementia caused by Alzheimer's. By 2050, the number is projected to reach 14 million. Alzheimer's disease is currently ranked as the sixth leading cause of death in the United States. In every 65 seconds, someone develops the disease, and it kills more people than breast and prostate cancer combined. Alzheimer's is the most common cause of dementia among older adults and accounts for 50 to 80% of dementia cases, as mentioned before. On average, a person with Alzheimer's lives for about 4 to 8 years after diagnosis, but they can live for as long as 20 years, and of course, this depends on other factors. Now, how does Alzheimer's affect the brain? So changes may begin a decade or more before memory or other cognitive problems appear. So during the preclinical stage of Alzheimer's disease, people seem to be symptom-free, but these changes are taking place in the brain. Abnormal deposits of proteins form these amyloid plaques and tau tangles throughout the brain. So these once healthy neurons stop functioning. They lose connections with other neurons and die. So many other complex changes are thought to play a role in Alzheimer's too. The damage initially appears to take place in the parts of the brain essential in forming memories. So as more neurons die, additional parts of the brain are affected and begin to shrink. So by the final stage of Alzheimer's, damage is widespread and the brain tissue has shrunk significantly. So this is a picture of a healthy brain and then the brain of somebody with severe Alzheimer's. So if we look at the natural history of Alzheimer's in this 4 to 8 year time span, you can see how it progresses. So as we just discussed, these brain changes occur far before it's diagnosed. So the most common early symptom of Alzheimer's is difficulty remembering newly learned information, because these changes typically begin in the part of the brain that affects learning. There may be subtle personality, mood, and behavior changes. Usually, family or others close to the person notice the symptoms. The patient typically has an idea that something is not right. Then it progresses into mild Alzheimer's disease. Now, in this stage is when it's usually diagnosed. So symptoms in this stage include difficulty learning new material, decline in recent memory, difficulty performing tasks. Somebody's appearance can deteriorate, decreased concentration and judgment, time disorientation, difficulty finding words or naming objects. In this stage, since the person is usually aware of their forgetfulness, they may withdraw socially and have feelings of shame. Helplessness and frustration may be seen. As Alzheimer's disease progresses, people experience greater memory loss and other cognitive difficulties. Problems can include wandering and getting lost, trouble handling money and paying bills, repeating questions, taking longer to complete normal daily tasks, and personality and behavior changes. Now, of course, just remember that there's so much overlap between these stages. It's really hard to tell when somebody progresses from mild to moderate. So in moderate Alzheimer's disease, damage occurs in the areas of the brain that control language, reasoning, sensory processing, and conscious thought. Memory loss and confusion grow worse, and people begin to have problems recognizing family and friends. They may be unable to learn new things, carry out multi-step tasks, such as getting dressed or cope with new situations. In addition, people at this stage may have hallucinations, delusions, and paranoia, and they may behave impulsively. Ultimately, it progresses to severe Alzheimer's disease. The plaques and tangles spread throughout the brain tissue shrinks significantly. The last stage is an almost complete deterioration of bodily function, personality, and behaviors. People cannot communicate and are completely dependent on others for their care. And near the end, the person may be in bed for most or all of the time as the body just completely shuts down. So let's move on to diagnosis. Detecting mild cognitive impairment due to Alzheimer's disease provides an opportunity to begin management that may help preserve existing function as long as possible. So the American Academy of Neurology practice guidelines recommend that clinicians assessing cognitive impairment should use a brief, validated cognitive assessment instrument in addition to eliciting a history of cognitive concerns. The most commonly used instrument is called the clock drawing test. So on one hand, people are asked 3 words to memorize, and then they are asked to repeat those words in 3 minutes. But within that time frame, they are asked to draw a clock. So if you look at the drawings of this clock, you will see people they'll draw a normal clock. In mild cognitive impairment and maybe early Alzheimer's disease. You can see kind of how they would draw their clock. I would honestly say that I would see this type of clock more like in a moderate Alzheimer's disease. Then you ask them to remember the 3 words, and then there's a score that goes along with this. So this is a very quick test that can be done in the doctor's office. So if somebody tests positive for mild cognitive impairment, then they need a more formal assessment for diagnosis. So they can go on and get the mini mental state examinations. So this could be done by their primary care physician. This would take about 20 to 30 minutes, or even better yet, they can have a referral to a neuropsychologist or a geriatric psychiatrist, and this really would be best. And then they should have serial assessments over time to monitor changes in their cognition. But the point is to have the correct diagnosis, if this would be something like an Alzheimer's or another type of dementia. So as we're getting into treatment, I do want to just say a general word. So a common approach to difficult behaviors in all types of dementia is to go right to medicating patients with tranquilizers, sedatives, or antipsychotics. But that is risky, and it's often not what is best. So experts recommend trying behavior management first, and for good reasons. It tends to be more effective in the long run. And really, medicating patient is using something that is actually referred to as a chemical restraint. But behavior management has no dangerous side effects, and it actually leads to a better care relationship. So non-drug approaches to managing behavior symptoms promote physical and emotional comfort. And many of these strategies aim to identify and address needs that the person with dementia may have difficulty expressing as the disease progresses. So non-drug approaches should always be tried first. Unfortunately, there is no cure, prevention, or treatment to slow the progression of Alzheimer's disease, but there are 5 prescription medications approved by the U.S. Food and Drug Administration to treat its symptoms. So again, I want to reiterate that current medications cannot stop the damage or progression of Alzheimer's and the damage it causes to brain cells, but they can help lessen or stabilize symptoms for a limited time by affecting certain chemicals involved in carrying messages across the brain's nerve cells. So doctors sometimes can prescribe both types of medications together. So medications for early to moderate stages. All of the prescription medications currently approved to treat Alzheimer's symptoms in early to moderate stages are from a class of drugs called cholinesterase inhibitors. Cholinesterase inhibitors are prescribed to treat symptoms related to memory, thinking, language, judgment, and other thought processes. Additionally, cholinesterase inhibitors prevent the breakdown of acetylcholine, a chemical messenger important for learning and memory. This supports communication among nerve cells by keeping acetylcholine high. These medications can delay or slow the worsening of symptoms, but their effectiveness really varies from person to person. They are actually very well tolerated. If side effects occur, they commonly include nausea, vomiting, loss of appetite, and increased frequency of bowel movements. It is strongly recommended that a physician who is experienced in using these medications monitor patients who are taking them, and that the recommended guidelines be strictly observed. So there are 3 cholinesterase inhibitors that are commonly prescribed. Donepezil is the most commonly prescribed under the brand name that is Aricept. The second is galantamine, which is Razodine. The third would be rivastigmine. The Aricept is approved for all stages of Alzheimer's, but the last 2 for only the mild to moderate stages. Another medication is called memantine, which is Namenda. And there's also a combination medication of memantine and donepezil. And those are approved by the FDA for the treatment of moderate to severe Alzheimer's. Memantine is prescribed to improve memory, attention, reason, language, and the ability to perform simple tasks. So this can be used alone or with other Alzheimer's disease treatments. There is some evidence that individuals with moderate to severe Alzheimer's who are taking a cholinesterase inhibitor might benefit by also taking memantine. So memantine acts differently. It regulates the activity of glutamate, a chemical involved in information processing, storage, and retrieval. And it improves mental functioning and ability to perform daily activities for some people. Common side effects can be headache, constipation, and dizziness. And you have this all in a lovely chart for you right here. Some of the side effects were not mentioned here, but you can also look this over. So I do want to mention that there is a new medication only for Alzheimer's. And while this is actually pretty exciting news, it has also been called a lackluster medication with a high price tag. So on June 7, 2021, the FDA provided accelerated approval for the newest medication, and this is called Aduhelm. Now, this medication actually helps to reduce these amyloid deposits in the brain, and it may help slow the progression of Alzheimer's. However, it has not yet been shown to affect clinical symptoms or outcomes. So this would be the progression of cognitive decline or dementia. So there has been several studies, and one shows that it's not effective and one shows that it is. So this accelerated approval means that they have been released for general use early, because they have the potential for benefit, but they don't have any long-term data yet. So the results, I would say, are inconclusive. So basically, to be continued on this new medication. But it is exciting because at least we have something new, and something that is actually shown to reduce these amyloid deposits in the brain. So we are going to move on to the second most common cause of dementia among older people, which is vascular dementia. And this is very different from Alzheimer's because this is a decline in thinking skills caused by conditions that block or reduce blood flow to various regions of the brain, depriving them of oxygen and nutrients. So changes in thinking skills sometimes occur suddenly after a stroke, which blocks major blood vessels in the brain. But thinking difficulties may also begin as mild changes that gradually worsen as a result of multiple minor strokes or another condition that affects smaller blood vessels, leading to widespread damage. Often we talk about how unhealthy lifestyles can put people at risk for a cardiovascular event. So this would be something like a heart attack or a stroke. But we never talk to people about the fact that those same lifestyles can also lead to dementia. So risk factors for vascular dementia include the following: high blood pressure, diabetes, arteriosclerosis, so this would be hardening of the arteries, hyperlipidemia, so high cholesterol levels, smoking, any history of a heart attack or stroke, and atrial fibrillation. High blood pressure, diabetes, and atherosclerosis damage blood vessels in the brain. Atrial fibrillation increases the risk of strokes due to blood clots from the heart. So unlike these other causes of dementia, unlike all of the other causes of dementia, the risk factors for vascular dementia are modifiable. That means that they can be changed, at least most of them. So symptoms of vascular dementia really depend on the part of the brain it affects and the severity of the blood vessel damage. So again, unlike the other dementias which tend to progress continuously, Vascular dementia may progress in steps, so symptoms may worsen suddenly, then plateau or lessen somewhat. They can then become worse months or years later, or it may be so subtle that dementia may seem to develop gradually and continuously instead of in steps. So memory loss, difficulty planning and initiating actions or tasks, slowed thinking, they may have a tendency to wander, are similar to those of other dementias. However, compared with Alzheimer's disease, vascular dementia tends to cause memory loss later and to affect personality less. Vascular dementia tends to cause difficulty with the following earlier than Alzheimer's disease: planning, solving problems, handling complex tasks, and using good judgment, called executive function. Initiating actions, thinking may be noticeably slow. About 6 in 10 people die within 5 years after symptoms begin, and this is often due to a stroke or a heart attack. Diagnosis, as far as diagnosis, in 2011, the American Heart Association and the American Stroke Association issued a joint scientific statement on vascular contributions to mild cognitive impairment and dementia. The diagnosis includes the following criteria. So the diagnosis of dementia or mild cognitive impairment is confirmed by neurocognitive testing. But there is also brain imaging evidence, so usually an MRI, confirming a recent stroke or other vascular changes whose severity and pattern of affected tissue are consistent with the types of impairment documented in cognitive testing, and that there's no other evidence of non-vascular factors that may be contributing to cognitive decline. And because vascular dementia often goes unrecognized, many experts recommend professional cognitive screening for everyone considered to be at high risk, including those who have a history of stroke or heart attack. An example of this might be a non-adherent diabetic patient who hasn't been following their insulin regimen. So over time, diabetes destroys the blood vessels of the body. So in their brain, they would have blood vessel changes and maybe even some mini bleeds or strokes, and that could cause a vascular dementia. So, of course, treatment often focuses on managing the health condition and risk factors that contribute to vascular dementia. So this would be maintaining a healthy blood pressure, preventing or controlling the diabetes. So controlling the glucose levels helps protect the brain blood vessels from further damage. Of course, we need people to stop smoking, because smoking damages blood vessels everywhere in the body. Exercise is very important. Regular physical exercise should be a key part of everyone's wellness plan. And keeping cholesterol in check, a healthy low-fat diet and cholesterol-lowering medications reduces the risk of strokes and heart attacks leading to vascular dementia. Memantine is also approved for moderate to severe dementia and has been shown to improve functional levels and lessen care dependency in vascular dementia also. So again, that can be prescribed and at least tried, although again, remember that it is limited in efficacy. And of course, ruling out any conditions and eliminating other medications that can masquerade as dementia, as discussed earlier. And I will very briefly discuss mixed dementia, because this is a condition in which brain changes of more than one cause of dementia occur simultaneously. In the most common form of mixed dementia, the abnormal protein deposits associated with Alzheimer's disease coexist with blood vessel problems linked to vascular dementia. There is one study that found up to 54% of this in autopsies. Now, Alzheimer's brain changes also often coexist with Lewy bodies. In some cases, a person may have brain changes linked to all three conditions: Alzheimer's disease, vascular dementia, and Lewy body dementia. So researchers, of course, don't know exactly how many older adults currently diagnosed with a specific type of dementia actually have mixed dementia, but autopsies indicate that the condition may be significantly more common than previously realized. All right, let's move on to Lewy body dementia. So it seems that Dr. Lewy was a colleague of Dr. Alzheimer. So he was a neurologist who discovered the hallmark abnormal microscopic deposits that damage brain cells over time in this type of dementia while working with Dr. Alzheimer in his laboratory during the early 1900s. Alpha-synuclein protein, the chief component of Lewy bodies, is found widely in the brain in Lewy body dementia. This type of progressive dementia leads to a decline in thinking, reasoning, and independent function. So if you look at this graph, you can see the Lewy body and the nucleus. Now, we're not really sure, but a study that was published on July 29, 2019 in Scientific Reports suggests that Lewy bodies are problematic because they pull this alpha-synuclein protein out of the nucleus of brain cells. And they think that the alpha-synuclein's role in DNA repair may be crucial in preventing cell death. So this function may be lost in brain diseases such as Lewy body dementia, and maybe even in Parkinson's too, leading to widespread death of neurons. The symptoms of Lewy body's dementia are many. So there's changes in thinking and reasoning, confusion and alertness that varies significantly from one time of day to another or from one day to the next. There can be slowness, gait imbalance, and other even Parkinson-like movement features, very well-formed visual hallucinations, delusions, trouble interpreting visual information, sleep disturbances, malfunctions of the autonomic nervous system, memory loss that may be significant but less prominent than in Alzheimer's. Lewy bodies are also found in other brain disorders, so they can be found in Alzheimer's disease and especially in Parkinson's disease dementia. So many people with Parkinson's eventually develop problems with thinking and reasoning, and many people with Lewy body dementia experience movement symptoms similar to Parkinson's. So hunched posture, rigid muscles, a shuffling walk, and trouble initiating movement. So these overlap in symptoms and other evidence suggests that Lewy body dementia, Parkinson's disease, and Parkinson's disease dementia may be linked to the same underlying abnormalities in how the brain processes the protein alpha-synuclein. So many people with both Lewy body dementia and Parkinson's dementia also have plaques and tangles, and this is the hallmark brain changes linked to Alzheimer's disease. So this is all still being figured out yet. So unfortunately, there's no single test that can conclusively diagnose Lewy body dementia. So many experts now believe that Lewy body dementia and Parkinson's disease are two different expressions of the same underlying problems with brain processing of the protein alpha-synuclein. But most experts recommend continuing to diagnose the two separate. So the diagnosis of Lewy body dementia is present when dementia systems consistent with Lewy body dementia develop first. So when both dementia symptoms and movement symptoms are present at the time of diagnosis. When dementia symptoms appear within 1 year after movement symptoms. So the diagnosis of Parkinson's disease dementia when a person is originally diagnosed with Parkinson's based on movement symptoms, and dementia symptoms don't appear until a year or more later. So if there's no dementia it's diagnosed as Parkinson's. Since Lewy bodies tend to coexist with Alzheimer's brain changes, it may sometimes be hard to distinguish between Lewy body dementia from Alzheimer's disease, especially in the early stages. But there is a Lewy body composite risk score that has been developed to assess patients with this. It does cover a 10-question that deal with motor symptoms, balance, stiffness, and non-motor symptoms. So this may help come to a diagnosis, but due to the incomplete specificity in the clinical diagnosis and the pathological definition of the disease, really the only way to secure a definite diagnosis is by autopsy. So there are unfortunately no treatments that can slow or stop the brain cell damage caused by Lewy body dementia. So current strategies focus on helping symptoms. Now, the cholinesterase inhibitor drugs are the current mainstay for treating thinking changes in Alzheimer's. They may help certain Lewy body dementia symptoms. The antipsychotic drug should be used with extreme caution in Lewy body dementia. Although physicians sometimes prescribe these drugs for behavioral symptoms that occur in Alzheimer's, they may cause serious side effects in as many as 50% of those with Lewy body dementia. Now, antidepressants may be used to treat depression, which is common with Lewy body dementia, Parkinson's disease, and Alzheimer's. The most commonly used antidepressants are selective serotonin reuptake inhibitors. Clonazepam may be used to treat the sleep disorders. Like other types of dementia that destroy brain cells, Lewy body dementia gets worse over time and, of course, shortens lifespan. So a lot of awareness was raised about Lewy body dementia when Robin Williams died by suicide. If you remember who Robin Williams is, he was a famous comedian who made a lot of movies. Many of you from my generation would know who he was. Maybe people in the younger generation wouldn't remember. But a few years ago, he died by suicide. Now, what people maybe don't know was what he went through the years before his death. Now, his wife, Susan Snyder Williams, wrote an article entitled "The Terrorist Inside My Husband's Brain." And I encourage you to read it because it will give you a lot of insight into their experience with Lewy body dementia. And they didn't know that he had it until after he died. Now, when the autopsy results were revealed, she writes in the article that their reactions were all the same, that Robin's was one of the worst Lewy body dementia pathologies that they had seen, and there was nothing else anyone could have done. Now, I also came across a lady who was suffering from post-traumatic stress disorder. And this comes because of her husband who had Lewy body dementia. And he became very violent and very abusive, again, without her knowing that he had Lewy body dementia. He had never been like that. He had even held a gun to her head and said to her, "What would you do if I pulled the trigger?" among many other things. And then finally, he was diagnosed with Lewy body dementia. So this leads me to discuss another aspect of dementia that no one seems to discuss, and that is the fact that people can become psychotic, angry, mean, verbally abusive, and sometimes violent. These are behavior changes that dementia patients can experience. So the disease can sometimes change the most kind, gentle, docile individuals. And unfortunately, Lewy body dementia and even Parkinson's dementia seem to be the worst type of dementia for this to happen in. So let's discuss these psychotic behaviors. So the prevalence of psychoses across dementia types if you look at the different dementia types in Alzheimer's disease, about 30% can experience psychosis. In vascular dementia, it's much lower at only 15%. But look at the Lewy body dementia, 75%. And in Parkinson's disease dementia, again, where there are a lot of Lewy bodies found, it's 50%. And then, of course, the frontotemporal dementia, it's only 10%. So that's why those patients, especially the Lewy body dementia and Parkinson's, really should be treated by a geriatric psychiatrist. So when I talk about psychoses or psychosis, we're talking about agitation, aggression, hallucinations and delusions, formal thought disorder. So formal thought disorder can include incoherent discourse, abnormal motor behavior, so abnormal movements. People can also have blunted affect, so staring off into space, not speaking, so poverty of speech, and even apathy. It's like they don't have any emotion. So now we are going to move on to Parkinson's disease dementia. Now, what is curious to me is that Robin Williams was actually diagnosed with Parkinson's disease before his death. So Parkinson's disease dementia is a decline in thinking and reasoning that develops in many people living with Parkinson's at least a year after diagnosis. The brain changes caused by Parkinson's disease begin in a region that plays a key role in movement, leading to early symptoms that include tremors and shakiness, muscle stiffness, a shuffling step, stooped posture, difficulty initiating movement, and a lack of facial expression. As brain changes caused by Parkinson's gradually spread, they often begin to affect mental functions, including memory and the ability to pay attention, make sound judgments, and plan the steps needed to complete a task. The key brain changes linked to Parkinson's disease and Parkinson's disease dementia are abnormal microscopic deposits composed chiefly of alpha-synuclein, a protein, again, found widely in the brain with a normal function not fully known. The deposits are called Lewy bodies, again, after Frederick H. Lewy, the neurologist who discovered them while working with Dr. Alzheimer's in his laboratory in the early 1900s. The National Parkinson's Foundation reports that 1 million Americans have Parkinson's disease. Recent studies following people with Parkinson's disease over the entire course of their illness estimate that between 50 to 80% of those with the disease may experience dementia. And some studies have reported that the average time from onset of Parkinson's to developing dementia is about 10 years. So there's certain risk factors at the time of Parkinson's diagnosis that may increase future risk for dementia. These include advanced age, the greater severity of motor symptoms, and mild cognitive impairment. The presence of hallucinations in a person who doesn't yet have other dementia symptoms may also increase their risk for dementia. Also, excessive daytime sleepiness, and a Parkinson's symptom pattern known as postural instability and gait disturbance, which includes freezing in mid-step, difficulty initiating movement, shuffling, and problems with balancing and falling. All of these may indicate a future risk of dementia. So symptoms of Parkinson's dementia, of course, would be changes in memory, concentration, and judgment, trouble interpreting visual information, muffled speech, visual hallucinations, delusions, especially paranoid ideas, changes in mood, so depression, irritability, and anxiety, sleep disturbances, including excessive daytime drowsiness and rapid eye movement, and sleep disorder. So again, there is no single test that can, or a combination of tests that conclusively determines that a person has Parkinson's disease dementia. So remember, it is Parkinson's disease dementia when the movement symptoms are first and they don't develop dementia until at least a year later. It is Lewy body dementia when they develop the dementia first, and movement symptoms do not come until at least a year later. So movement symptoms first, Parkinson's. Dementia first, Lewy body dementia. So again, treatments, there are no treatments, unfortunately, to slow or stop the brain cell damage caused by Parkinson's disease dementia, but certain strategies on improving symptoms. The cholinesterase inhibitors, so the drugs that are currently the mainstay for treating the cognitive symptoms in Alzheimer's, may help Parkinson's disease dementia symptoms, including the visual hallucinations, the sleep disturbances, and changes in thinking and behavior. The typical Parkinson's drugs, so the carbidopa, levodopa, are prescribed to treat the Parkinson's movement symptoms. However, sometimes those medications can aggravate the hallucinations and the confusion. The depression medications are used, so the SSRIs are used to treat the depression, which are both common in both of those types of medications. Clonazepam and melatonin are used to treat the sleep disorders. There is a huge caution. So the antipsychotic medications, especially the older ones, should be avoided. About 60% of people with these two types of dementias experiencing worsening symptoms. So they can have sedation, impaired swallowing, or more dangerous is something called neuroleptic malignant syndrome. NMS is a life-threatening condition characterized by fever, generalized rigidity, and muscle breakdown following exposure to the traditional antipsychotic medications. And just in general, antipsychotics have been shown to increase death in the elderly anyway, just in general. So that is why, again, I will reiterate that these patients really should be under the care of a geriatric psychiatrist. The last type of dementia that we're going to talk about is called frontotemporal dementia. This type of dementia used to be called Pick's disease, again, named after a doctor, Dr. Arnold Pick, a physician who in 1892 first described a patient with distinct symptoms affecting language. Some doctors still use the term Pick's disease. Frontotemporal dementia, or FTD, is actually refers to a group of disorders caused by progressive nerve cell loss in the brain's frontal lobes. So this would be the areas behind the forehead or its temporal lobes, the regions behind the ears. The nerve cell damage caused by FTD leads to a loss of function in these brain regions, which variably cause deteriorations in behavior, personality, and or difficulty with producing or comprehending language. It is much less common than Alzheimer's disease, but in the 45 to 65 age range, it's nearly as common as younger onset Alzheimer's. Only rough estimates are available, but there may be 50 to 60,000 people with this type of dementia in the United States, the majority of whom are between 45 to 65 years of age. So there are several different types, but the two most common are behavior variant frontotemporal dementia, and this is characterized by prominent changes in personality and behavior that often occur in people in their 50s and 60s, but it can develop as early in their 20s or as late as their 80s. So in this type of dementia, the nerve cell loss is most prominent in areas that control judgment, empathy, and foresight, among other abilities. There's also primary progressive aphasia, and this is the second major form of this type of dementia that affects language skills, speaking, writing, and comprehension. So PPA normally comes in midlife before age 65, but can occur in late life also. So the symptoms are behavioral changes. So the most common involve extreme changes in behavior and personality. So this includes increasingly inappropriate behavior, social behavior, loss of empathy and other interpersonal skills, such as having sensitivity to others' feelings, lack of judgment, loss of inhibition, a lack of interest or apathy, which can be mistaken for depression, repetitive, compulsive behavior such as tapping, clapping, or even smacking lips, a decline in personal hygiene, changes in eating habits, usually overeating or developing a preference for sweets and carbohydrates, eating edible objects, compulsively wanting to put things in the mouth. There are also speech and language problems, and then there's also 3 subtypes, which we're not going to get into. There can be increasing difficulty in using and understand written and spoken language, such as trouble finding the right word to use in speech or naming objects, trouble naming things, possibly replacing a specific word with a more general word, such as it for pen, no longer knowing word meanings, having hesitant speech that may sound telegraphic, making mistakes in sentence construction. And there's also some rarer subtypes that are characterized by problems with movement, similar to those with Parkinson's disease or ALS. So movement types may include tremor, rigidity, muscle spasms, poor coordination, difficulty swallowing, muscle weakness, and inappropriate laughing or crying. So the diagnosis of the behavioral variant are based on expert evaluation by a doctor who is familiar with these disorders. The type of problems experienced by the patient and the results of neurological exams are basically the core of the diagnosis. So brain scans such as an MRI. There's also another test called glucose positron emission scans are very helpful additional tests, but they may be interpreted in the context of the patient's history and a neurological exam. So causes and risk factors. So this type of dementia is inherited in about 1/3 of cases. So genetic counseling and testing are available now in individuals with family histories. But otherwise, there are no known risk factors for any of the frontotemporal degenerations except for a family history or a similar disorder. So unfortunately, again, there's currently no cure or specific treatment for this type of dementia. Drugs used to treat or Alzheimer's disease, unfortunately, don't seem to be helpful for people with this type of dementia. And it actually, some of them may worsen the symptoms. Certain medications and speech therapy can help manage some of the symptoms. And again, antidepressants may reduce behavioral problems. So again, the antidepressant medications have been effective in some people. Antipsychotics, because the patients are younger, can sometimes be used to combat the behavioral problems. However, again, they have to be used in caution, again, because of the side effects. Again, if they're older, they can cause an increased risk of death. So unfortunately, like most dementias, this inevitably gets worse over time. But the speed of decline really differs from person to person and the type of dementia that they have. So in conclusion, I just want to really reiterate the importance of early diagnosis for all dementia patients, because reluctance to go to the doctor when somebody or a family member has memory problems is certainly understandable because there's a lot of denial. So some people try to hide their symptoms or a family member tries to cover for them. And that is easy to understand, honestly, because dementia is associated with loss. It's associated with a loss of independence, a loss of self, There's a lot of grieving that goes on, and many people wonder if there's even a point in getting a diagnosis if there's no cure for the disease. And it honestly is true that if somebody has dementia, there's really not a cure. However, getting an early diagnosis is indispensable because there are access to treatment options. So while current medications do not prevent, stop, or reverse dementia, they can help lessen the symptoms in some of these types of dementia, such as memory loss and confusion. And even though it is for a limited time, an early diagnosis provides individuals with a better chance of benefiting from the treatment. It also gives them a chance to prioritize their health. So lifestyle changes, especially in the vascular dementia. So controlling blood pressure, stopping smoking, participating in exercise, and staying mentally and socially active may even help preserve their cognitive function. There's also emotional and social benefits. So receiving an early diagnosis may help lessen some of the anxieties about why an individual is experiencing symptoms. The family also has the opportunity to maximize their time together and also to access resources and support programs. What many people don't know is that at the start of an illness, they are qualified for palliative care. And unfortunately, a lot of people think that palliative care is equal to end-of-life care, and that's completely untrue. You qualify for palliative care at the beginning of any serious illness, and it comes in many different forms. There's also more time to plan for the future. So planning ahead allows the individual to express wishes about legal, financial, and end-of-life decisions. The family will be able to review and update legal documents, discuss finances and property, and identify care preferences. The individual can also address potential safety issues such as driving and wandering, and all of this can be done ahead of time. And finally, early diagnosis saves costs of medical and long-term care for families. All right, thank you so much for listening today. Again, my name is Terry Duran, and now it is time to take your quiz.